So we are going to look at the overview and scope of this burden in Uganda, management, treatment, and surgery, just like our moderator, Dr. Muhozi, has alluded to. So by way of introduction, congenital heart disease or a congenital heart defect is a heart abnormality which is present at birth. The problem can affect the heart walls, the heart valves, the blood vessels. And this can range from simple conditions that don't cause symptoms to complex problems that cause severe life-threatening symptoms, as we shall see. So what is the Ugandan situation? According to Uganda Demographic and Health Survey 2016, 1.6 million children are born every year. Now just look at 1.6 million children born every year. 1%, which is 16,000 children, suffer from congenital heart disease. So we can all see this is a big problem in Uganda we are facing. And to make it worse, 50% of the 16,000 children, and those are 8,000 children, have a defect which is serious enough to require an intervention. So if we look at the burden of Uganda, what's the burden of congenital heart disease in Uganda? There was a study which was done by Dr. Judith et al., and it was published in the Journal of African Health Sciences 2020. And they looked at the pattern of congenital heart disease among children presenting to the Uganda Heart Institute Mulago Hospital, and it was a 7-year review. So what were the findings? So just look at the sample size. It was 3,526. Now look at the number of cases. Isolated VSD, it was 921 with a percentage of 52. So it's under PDA, 760. ASD, we had 322. And endocardial cushion defects were 265. Pulmonary valve stenosis accounted for 226, which is 44%. Mitral valve prolapse accounted for 66, that's the number. Aortic valve stenosis accounted for 35, and the partial anomalous pulmonary connections accounted for 17. Then the coarctation of the aorta accounted for 14. So what about the previous slide was showing the cyanotics. So this current slide is showing us the children who had cyanotic heart disease in that study, the 7-year review study. As you can all see, Tetralogy of Fallot accounted for the biggest, 247, with an overall percentage of 7%. And truncus arteriosus accounted for 165. Double outright right ventricle accounted for 104. Pulmonary atresia 71. Tricuspid valve atresia 62. DTGA 53. And the anomalous pulmonary venous return accounted for 8. So before we go into the pathology, it is better for all of us to be on the same page. Since we have also undergraduate students who are following the presentation, it is better to understand the normal anatomy before we go for the abnormal pathology. So if we look at the blood flow, blood flows from the superior vena cava and the inferior vena cava. All that blood is drained in the right atrium. From right atrium, it goes to the right ventricle through the tricuspid valves, and then it goes through the pulmonary valves to the main pulmonary artery, and it's taken to the lungs. Now, all that blood on the right is deoxygenated. So that blood reaching the lungs, it is oxygenated by the lungs, and all that blood returns on the left atrium. From left atrium, it goes to the left ventricle through the mitral valves, and then it is ejected through the aortic valve to feed the whole body. So how do we classify congenital heart disease? There are majorly two. We have the cyanotic and the cyanotics. But for most of the listeners might be knowing that we have only a cyanotic and cyanotic, but we subdivide them further. So under the cyanotics, we look at the shunt lesions, which is to do with volume load lesions. And also we look at the obstructive lesions, and these are the pressure load lesions. What about these children who come in with cyanosis, the cyanotics? We also subdivide them into two. We have those cyanotics who have decreased pulmonary blood flow, as we shall see. And also we have the cyanotics who have increased pulmonary blood flow. So this is basically a list of the cyanotics, but we shall discuss the common ones because the time is limited, the 1 hour presentation. So we want to start with children who have a cyanotic congenital heart lesions with left to right shunting. So we have the atrial septal defects, ventricular septal defects, the atrioventricular septal defects, and the patent ductus arteriosus. So what about those babies who are cyanotic but they have increased pressure load? So the commonest are the valvular pulmonary stenosis, the valvular aortic stenosis, and the coarctation of the aorta. So let's start with the shunt lesions. The child comes in is pink, but is having a shunt lesion. The first shunt lesion we are going to discuss is the atrial septal defect. So it's the most common form of ASD, and it can occur in the portion of the atrial septum. We can have the secundum, the primum, or the sinus venosus. And commonly, they occur in the central part of the atrial septum. So the secundum ASD is the commonest, and majority of these cases are sporadic. However, there are some children who have ASDs and they are due to autosomal dominant inheritance, just like we see in the Holt-Oram syndrome. Holt-Oram syndrome is basically autosomal dominant, and it is to do with mutation in the TBX5 gene, which is obviously responsible for formation of the atrial septum and the upper limbs. So when you get a child with the upper limb deformities, please, that baby needs to be screened for the heart. So this is basically a summary of the different types of the atrial septal defects. So how does this child present? So most patients with ASDs actually are asymptomatic and may remain undiagnosed until later in life. And actually, in my experience, I've seen many children many patients who come to us 30 years and they don't know that they have even an ASD. So you might be there following the slides, but when you have an ASD which is not yet diagnosed. So even an extremely large secundum ASD, it rarely produces any clinical evidence of heart failure. And on close evaluation, younger children may show subtle failure to thrive, and older children may have varying degrees of exercise intolerance. So basically, should have a high index of suspicion, just like we shall look at the clinical presentations. So how do we make a diagnosis? Well, the first, in our resource limited setting, we start with a chest radiograph. And obviously, we shall see the enlargement of the right ventricle and atrium because the shunt is left to right. So the right heart chambers obviously will become bigger than the left. And this one is dependent on the size of the shunt. The other thing that we shall see on chest X-ray is the enlarged pulmonary artery and also the increased vascularity in the pulmonary. So echo is the definitive diagnosis, and it is non-invasive. And echo will help us, echocardiogram will help us to tell us the type of SD, whether it's secundum, primum, sinus venosus, or coronary sinus. It can also tell us its size and the shape. It can tell us the degree and direction of shunting, and also its effects on the right-sided heart chambers, and other lesions which are associated with the ASD. So how do we manage? Most of these children are normally asymptomatic. However, in rare cases, they may be symptomatic and we might need to give some diuretics. And obviously, closure of this SD is indicated if there's a large shunt, and that is when we do hemodynamic studies in the cath lab. The QP, the QS ratio of more than 1.5 is also an indication for closure. Medical management is rarely indicated, but if the shunt is significant and it is present by 3 years of age, we have to close this ASD. You should not postpone. This is the child who will need surgical closure. Or catheterization. We can have a device closure. So secundum SD can be closed by catheterization, but we should all note that primum ASD and sinus venosus ASDs, this is surgical closure. You cannot do device closure as far as the primum SD and sinus venosus SDs are concerned. It's only usual secundum SD. And also it should have they should have good rims. We have the SVC rim, the aortic rim, IVC rim. So when we are doing echoes, usually we assess for the rims for suitability of device closure. So the second lesion, which is shunt lesion, is VSD, as you can see. And VSD, this is a common cardiac malformation, and it accounts for 25% of the congenital heart disease. The defects may occur in any portion of the ventricular septum, and most common are the membranous type. So the membranous is the commonest type of the VSD, and VSDs in the mid portion or apical region of the ventricular septum are usually masticular in type, and they are so the ones we call the Swiss cheese. Sorry? Okay. So we are going to look at classification of these VSDs. So we have the membranous, the atrioventricular septal defects, we have the masticular and the supracrystal. And clinical presentation, it varies according to the size of the defects, the pulmonary blood flow, and the pressure. So a child with a small VSD might be asymptomatic compared to a child with a large VSD. So small VSDs with trivial left-right shunts basically are the most common, and these patients are asymptomatic, and the cardiac lesion is usually found during routine physical exam. So a patient may just come for any other complaint, but as you auscultate the heart, you get a pansystolic murmur, and it is basically at the left lower sternal border, which is the fourth left lower, left intercostal space, left sternal edge. However, for large VSDs, these ones will present with congestive heart failure, they have dyspnea, feeding difficulties, and these are the babies who have poor growth. The mother will come to you, the doctor, my baby is not putting on weight, has difficulty in breathing, they have excessive sweating, and they get recurrent pulmonary infection early in life. So when we examine these babies with large VSDs, initially they will appear well because obviously because in the neonatal period, if we remember fetal saturation, the pulmonary vasculature, the pulmonary pressures are normally higher than the systemic pressures. So normally, if they are small, like a neonatal period, the shunt will not be left-right because the pressures on the right will be higher than the pressures on the left. So there will be minimal shunting. So the patient might be asymptomatic. But obviously, as the child becomes bigger, then the shunt becomes eminent, and the patient then develops the symptoms of wasting, excessive sweating, increased work of breathing, subcostal restriction. Okay. So there are some tests we do. Sometimes when you do an EKG, you can get left ventricular hypertrophy. Chest X-ray for small VSD, it might look normal. But if the VSD is large, then you'll have biventricular hypertrophy. Because then if you do a chest X-ray, you'll get gross cardiomegaly with obvious prominence of both ventricles, left atrium and pulmonary artery. And also the pulmonary vascular markings are increased. And these are the children where you get frank pulmonary edema. And obviously the echo will confirm the diagnosis, and it will tell us the type of lesion. It will tell us the shunting and the size of the shunt. So important to note, muscular VSDs are most likely to close up to 80%. And membranous VSDs up to 35% during the first 2 years of life. And these are the babies who live a normal life with no restrictions. And usually surgery is not recommended. Endocarditis prophylaxis is no longer recommended for dental visits and surgical procedures. So for moderate to large VSDs, usually these babies are symptomatic and they need nutritional support. And we have to control the heart failure because depending on the severity. So these are the babies normally who come to us. And in most cases, these are the patients who initially are treated for severe pneumonia. They treat them for severe pneumonia and they fail to improve on treatment. Reason being, they are in congestive heart failure. So it is important whenever we get a child who has signs of pneumonia, it's better also to examine the cardiovascular system in detail. So basically we give them anti-failure treatment, the diuretics, the ACE inhibitors, and spironolactone if they need American Heart Association stage 3 and stage 4. Inotropes for severe diseases, and when they have pneumonia, as I said, we have to give them antibiotics. So what are the indications for surgery? Because there are so many patients who can have heart disease in health center for, and you are just maintaining them on diuretics, yet these are the candidates for surgery. So when should you decide that these are the patients who should see the cardiac surgeon? So if patients who have large defects and in whom clinical symptoms and failure to thrive cannot be controlled. A patient is having a cardiac lesion, a large VSD, and is not putting on weight. Please, this is surgical disease. Don't sit on this patient. Refer patient for urgent surgery. Patients who have moderate large defects and they have pulmonary hypertension, and these are normally 6 to 12 months of age, refer for heart surgery. Don't sit on these patients. Older than 24 months with the QP/QS ratio greater than 2.1, 2 to 1. Obviously, this one we do this after doing hemodynamic studies in the catheterization lab. And every child who has a supracrystal VSD, however small it is surgery. Because supracrystal VSDs are associated with aortic regurgitation. So a small supracrystal VSD is surgical disease. Don't say this child is having a small supracrystal VSD, let us wait. They stand a risk of aortic regurgitation, so we should not sit on these patients. These are the patients who need urgent referral. So the other shunt lesion is the patent ductus arteriosus, and it is a connection between the descending aorta and the pulmonary artery. So usually small PDAs are asymptomatic. However, when they come to hospital, you can feel a continuous machinery murmur, and this here you have to take attention. And large PDAs will result in heart failure, and just like we see them we see patients with a large VSD. And patients with large PDA, normally they have retarded growth. And when you auscultate, you get the machinery murmur. So how do you make a diagnosis? When you do an EKG, for a small PDA, it might be normal, and even chest X-ray will be normal. But moderate to large shunts, when you do a chest X-ray, they will have a cardiomegaly, increased pulmonary vascularity, and when you do an EKG, you can have evidence of left ventricular hypertrophy. And if, in case they get pulmonary hypertension, then you get right. Someone turn off your mic, please. Thank you. So how do we treat these patients with PDA? So ideally, in good settings, every newborn should have a neonatal echo done, because these are congenital heart diseases. Babies are born with them, so we can catch them early in life, just in the newborn period. So if a full term is delivered or a preterm is delivered, it would be good to screen all neonates for congenital heart abnormalities. Just like how Ministry of Health is now emphasizing newborn screening for sickle cells. I wish Ministry of Health would borrow a leaf, just like they screen newborn, like how they do newborn screening for sickle cells. I wish they would also start that program, newborn screening for congenital heart disease. Would reduce on some of these late presentations to hospital. So full-term newborns, spontaneous closure after few weeks is uncommon, and the small PDAs, normally elective closure, is insignificant. So if we have moderate large PDA, then these ones we have to first give them diuretics, and we should close with catheterization. Good news, Uganda Heart Institute has a full-fledged catheterization lab. And these things are not being done outside Uganda. Uganda Heart Institute can close all these heart defects so far discussed 100%. So if you get a preterm and you on echo, you get a PDA. If in a health facility, if you can access indomethacin or ibuprofen, you should administer it, and it is effective before the age of 2 weeks. And no, the dosages are all there. Orally, we give between 12 to 24 hours for 3 doses. First dose, you give a 0.2 per kg per dose. And second dose, you give 0.1 per kg per dose, just like the third dose. And the closure with catheterization, if newborns don't respond to treatment, you should send them to Heart Institute. So, if these babies are having moderate and large PDA, so that's when we should close surgically. And preterm newborns who don't respond to treatment, and also if there is a prior episode of endocarditis, they should be closed immediately. So this is the last shunt lesion, the AV septal defect. Yeah? I think I'll be rushing time. I can say there's like 15 minutes to go. So AV canal, it is also a common, and it is common in children with Down syndrome. And I don't have a pointer, but if you look on your left, that's the normal heart. Now, if you look on your extreme right, you can see there's an inlet VSD. I don't know how you can put a pointer. Let me try to put a pointer. So you can see this is an inlet VSD, and this is the common AV valve. This is the common AV valve. And then from here to here, that's the primum ASD. From here to here is the inlet VSD. So AV septal defect, you have a complete AV septal defect. You have the presence of both the inlet VSD and you have the primum ASD. There are different types of atrioventricular septal defects. We have the complete, we have the partial, okay? And we have the transitional AV canal. But because of time, we shall not go into that. So how do we treat? Normally, such children with a complete AV septal defect, treatment is a bit complex, but the success rate is high. And all these babies should be done surgery in infancy. So when you get a child, and it is common in these children with Down syndrome, you get a child with Down syndrome and the diagnosis of atrioventricular septal defect is made. These are the patients who should be sent to Uganda Heart Institute for urgent surgical correction without delay. Okay, now I'm done with the cyanotics. So what about the cyanotics? These are the children who present with, who produce cyanosis when there is either obstruction to right ventricular outflow tract obstruction, or it is because of the persistent fetal pathway. So these are the types, these are some of the types of the cyanotic heart disease, and we subdivide them. As we said earlier, it can be because of decreased pulmonary blood flow or increased pulmonary blood flow. But under the increased blood flow, I'll look at few because of time, and also we shall look at Tetralogy of Fallot for decreased pulmonary blood flow. So I'm starting with cyanotic heart disease, but with increased pulmonary blood flow. So this is the common cyanotic lesion present in the newborn period, and it is due to ventricular arterial discordance, and this is secondary to abnormalities of the septation of the truncus, arteriosus, and the aorta arises from the right ventricle, and the pulmonary arises from the left ventricle. So we shall look at the I think this diagram. So look at the picture here. This is a summary of D, transposition of great arteries. Now, if you look at the left ventricle, in a normal person, the aorta is meant to arise from the left ventricle. But if you look at this diagram, it is the pulmonary artery which is arising from the left ventricle. And if you look at the right ventricle, it is the aorta which is arising from there. So this is the transposition of great arteries. And if you look at the blood flow, ideally we know that blood from the left ventricle should go the aorta to the blood, to the body. But in this case, blood from left ventricle is going to the lungs and oxygen for oxygenation, and all that blood is returning in the left atrium, the left ventricle. So you can see it is a parallel circulation, the same to right. The blood flow on the right is totally independent of blood flow on the left, unless there is a shunt, unless there is mixing. Okay, this is basically a summary of what I was saying. So we have different types of DTGA. We have one with intact ventricular septum, and we have one which has a VSD, which we shall look at later. So I want to start with the DTGA, but with intact ventricular septum. Sometimes we call it simple TGA or isolated TGA. Okay, so this is a child who needs shunts for survival because the shunt is intact. This is the child who will need a ductus arteriosus, a PDA, and this is the child who will require a foramen ovale for survival. Okay, so if you look at this B, you can see this is a TGA with intact ventricular septum. There is no VSD here. So this is the child who has totally parallel circulation. Blood on this side is totally independent of this. Now, what is making this baby survive? There's a duct here, which is allowing the blood on the left to mix with the blood on the right. This is the ductus arteriosus, which is allowing mixing of blood, so that now the blood on the left, because if you see very well, the systemic pressure, the aorta is arising from the right. So by default, the blood will come through the PDA and then also now to the lungs. So this will help the baby survive. That is why if this ductus arteriosus closes, then chances are high that you might lose this baby. So how does this baby present? Has TGA with intact ventricular septum. This is the baby who will be blue because there will be no adequate mixing unless we have big shunts which are allowing mixing of blood, since these are parallel circulations. And if this is not treated, most of these infants normally don't survive in the neonatal period. And hypoxemia is usually moderate to severe depending on the degree of atrial level shunting and whether the ductus arteriosus is open or closed. And this is a medical emergency, and we have to take an appropriate intervention to avoid the development of prolonged severe hypoxia and acidosis, which obviously will lead to death. So when we examine these babies, usually they will have cyanosis, and they will have a single out S2, and they can have a mama. It can be a mama of a PDA. And when we do an EKG, it can be normal in the neonatal period because the right side is normally dominant over the left in the neonatal period. And we can have a cardiomegaly. And when you do a chest X-ray, you will get that egg on sting appearance. Okay. So echo is diagnostic and it confirms the transposed vessels. And most importantly, if you have a TGA with intact ventricular septum, the size of the interatrial communication and the ductus arteriosus can be visualized and the degree of mixing assessed and pulsed and the color Doppler. So when we are doing echo, actually, we have to look at these shunts which are making this baby survive. So if if the baby has a PDA, The bigger the PDA, the better. And the larger the persistent foramen of ovary, the better for mixing of blood. Because remember, they are parallel saturation. So we need the chance for survival. So there are times when we do cardiac catheterization for patients where non-invasive imaging is inconclusive. And there are times when we do emergency procedures like Rushkin, which is a balloon atrioseptostomy. I'm going to show you the picture. So how do we manage these babies? You are a doctor in NICU, you are a doctor in Health Center 4, and the baby is diagnosed with the DTGA and is having an intact ventricular septum. If you're in a setting where you have prostaglandin E1, that is the first thing we have to do. So because we want to maintain the ductus arteriosus pattern so that now we improve on the oxygenation, because now there will be good mixing. However, as you are giving this prostaglandin, it has the risk of apnea. So you should be ready for endotracheal intubation. And you should make sure that once you are nursing a baby with a DTGA, this is the baby, you should prevent hypothermia because it intensifies the metabolic acidosis, which results obviously from the hypoxemia. So the patient should be kept warm. And also we should correct the acidosis and hypoglycemia. Now, there are times when you give IV prostaglandin in this child, and the child is still acidotic, is severely hypoxic, so we have to go and do an urgent intervention. It is a palliative intervention, and we call it Rushkin balloon atrioseptostomy. So what does this one mean? We create, if the baby has a tiny PFO and there is no mixing of blood, this baby is taken to catheterization lab. Obviously, it is Heart Institute which is having it, and we make the PFO bigger. So when you make the PFO bigger, then you increase on the mixing of blood, because that's our aim. We want to improve on the mixing of blood. So we make it bigger by doing, it's like you are creating, and you are doing an iatrogenic, you are making the PFO bigger. So this one gives you time before you do the curative surgery. However, if the surgery is planned during the first week of life and the patient is stable, then obviously we shall avoid the atrioseptostomy because the patient now will be going for the curative surgery. Okay. So the other thing we should know, if you have even if a patient is having a VSD, studies have shown that mixing is better at the atrial level. So if you have a PFO or an SD, mixing is better at SD level than the VSD. So still we need a balloon atrioseptostomy for proper mixing. Obviously, the mainstay of surgery is atrial switch. So this one, basically, you bring the pulmonary artery, which is on the left, is put back on the right side, and the aorta, which is in the right, is reimplanted on the left, and also the coronary arteries are reimplanted. And this is the total correction. It's the total correction. Now, this is the Rushkin procedure I was talking about. And this is basically, these are images of the cath lab. And if you look at the first one, the balloon is inflated. Yeah? Balloon is inflated in the left atrium. So what you do, you have to cross the right atrium because you come from the inferior vena cava. From inferior vena cava, you go to the right atrium. Right atrium, you have to cross through the foramen ovary. Okay. So you cross the foramen ovary, then you inflate the balloon and you suddenly pull. It is jacked suddenly so that now you rupture the foramen ovary. If you look at this bit, from left atrium, you jack it to the right atrium so that you perforate you make the PFO bigger so that you allow mixing of blood. And this should be done in a second. Now, the one with the VSD, This is better than DTGA with interventricular septum, but I will not take a lot of time because the time has gone. I will go straight to the LTGA. If you look at LTGA and DTGA, they are totally different. DTGA is just the DTGA, it is just the great vessels that are switched. Now, LTGA, if you look at B, there is ventricular inversion. If you look at this side, where the left ventricle is meant to be, they are inverted. And so we have what we call double discordance. The right ventricle is inverted, and the left ventricle, the positions are what? Inverted. And if you look at the great vessels also, they are switched. So we have a double discordance. Double discordance means left atrium is connected to the right ventricle, so it's discordant. But again, instead of the right ventricle giving you the pulmonary artery, it is also connected to the aorta here. And instead of left ventricle connected to the aorta, is connected to the pulmonary artery. So we have atrium to ventricle discordance, but also we have the artery to the ventricle discordance. That's why they call it double discordance. Okay. So we have total anomalous pulmonary venous return, and there are many types. There are different types. I don't want to go through that. But the commonest is total anomalous. All the 4 pulmonary veins drain in the right atrium, but there are many types. We have different types, as you can see. We have the supracardiac, we have the cardiac, and the intracardiac, and the mixed. So the other second last one is the truncus arteriosus. It is cyanotic, but with increased pulmonary blood flow. So basically, there is a good diagram that will show us all this. So this is the diagram of truncus arteriosus, okay? Truncus arteriosus, you have an outlet VSD here, and you have a common trunk. You cannot say that this is aorta or pulmonary artery. So you have a common trunk that divides into, this one constitutes the ascending aorta, and the pulmonary artery divides off the main trunk and continues as the left pulmonary and right pulmonary. Okay. However, there are different types of truncus arteriosus. We have type 1, we have type 2, we have type 3. What you are seeing right now is type 1. Type 1, this main pulmonary artery divides from the common trunk. But type 2, we don't have this main pulmonary artery. It is the left pulmonary artery and right pulmonary that divide posteriorly. Then type 3, they divide laterally from here, from the trunk laterally. Just like this, the repetition basically. Type 2 and type 3, no main pulmonary arteries are present, and the right and pulmonary arteries arise from the separate orifices on the posterior, and then lateral, which is type 3. So basically, they present with signs of heart failure, and echo confirms the diagnosis, and the surgery is excellent. So what do we do? So what do we do? So when we are doing surgery, we close the VSD, okay? We separate off we cut off this main pulmonary artery, and we put what we call a valved RV to PA conduit. So we close off this VSD. So this one is cut off. So this one will continue now as the aorta. So we connect the right ventricle to pulmonary artery conduit. It is valved here. So that now the physiology is back to normal. However, what you should know, it is done in stages, because when a baby comes and it's still young, the baby will have to grow as the baby grows. Normally, we do it between below 6 months of age for the first surgery, and normally the second surgery we do it when the baby is a bit older, preschool. Okay, all that is in the notes. So obviously, when a baby comes to, we have the medical management because they present in heart failure. So you have to manage the heart failure with heart failure medication, and also they are at risk of severe pneumonia. So you have to manage, if they have signs of pneumonia, manage the pneumonia and manage the heart failure. Stabilize the patient before you send them to the surgeon. There's a hypoplastic left heart syndrome, but I'll not go through that. The most important thing is with hypoplastic left heart syndrome, there is hypoplasia of the left heart structures. You can see, look at the hypoplastic left ventricle. Look at the ascending part of the aorta is hypoplastic. Okay, you can see the hypoplastic aorta. Okay, and normally there are ducts which make them survive. If you look at the left ventricle for a normal patient, everything is hypoplastic. So the mitral valve can be stenotic or arteritic. The aorta can be stenotic or arteritic. So how do we treat hypoplastic left heart syndrome? Basically, there's what we call Norwood's procedure. I will not go into that because time has. So I want to just look at the Tetralogy of Fallot as my last presentation. So Tetralogy of Fallot, basically there are 4 components in Tetralogy of Fallot. So we have the right ventricular tract obstruction, we have the hypertrophy of the right ventricle, and we have the large malaligned VSD, and we have the aortic override. And it's the commonest cause of cyanosis in these children with cyanotic heart disease. Now, the most important thing is there are children who have Tetralogy of Fallot who present early in life. There are those who present when they are old enough. So what determines this? So what determines this is the level, the severity of obstruction of the right ventricular outflow tract. Okay? And this is the repetition. So the degree of right ventricular outflow tract obstruction determines the timing of the onset of symptoms, the severity of cyanosis, and the degree of right ventricular hypertrophy. Okay? So when the obstruction is mild to moderate, then the patient may not have the obvious cyanosis, the so-called pink tophers. But when the obstruction is severe, these are the babies who present earlier on in life. So they present from birth, and they worsen when the ductus arteriosus begins to close. Okay, so basically this is a normal heart. So this is the malaligned VSD. This is the ventricular hypertrophy, this side. So we have the VSDs here, the ventricular hypertrophy, the aortic override, okay, the aortic override, okay, and the pulmonary stenosis here, or what we normally call the right ventricular outflow tract obstruction, which can happen at different levels. You can have the subpulmonic, you can have the so-called infundibular, you can have obstruction at the pulmonary valve, or you can have obstruction above the pulmonary valve, what we call the supravalvular pulmonary stenosis. So how do they present? Infants with mild degrees of right ventricular outflow tract obstruction may have symptoms of heart failure because the shunting might be left to right. But obviously, you can miss the cyanosis. But obviously, with the increasing hypertrophy and the infundibulum becoming hypertrophied, then cyanosis can later ensue in the first few months of life. I think this one I've mentioned it. Now, maybe the last statement I want to talk about are the test spells, which normally bring these patients to hospital. We call them test spells. Other books call them hypercyanotic spells, and it's an emergency. How do they present? Normally, there's a trigger. It can be after excessive crying, after defecation, if there's a stressful environment. And for bigger children, they tend to squat. And when you listen, in a child who has a third spell, because ideally in a normal person with Tetralogy of Fallot, they have a mama of pulmonary stenosis. But when they get a third spell, the mama will disappear. So this is a boot-shaped heart. Whenever you do a chest X-ray and you get a boot-shaped heart, you should think of Tetralogy of Fallot. And this is the patient you should send for a cardiac echo to confirm. So this is a 2D parasternal long axis view. As you can see, the VSD is this one here. This is the VSD, okay? The overriding of the aorta, you can see this aorta, half of it is in the right ventricle, you can see here, and half of it is in the left ventricle, so there is overriding. And if you see the right ventricle, it is hypertrophied, okay? So these patients with Tetralogy of Fallot have complications. They are at risk of getting cerebral thrombosis. They get brain abscesses because their shunts are right to left. So the lungs are not purifying their blood. So most of the blood is shunting from right to left, and all that blood from the left ventricle is going to the systemic circulation. And remember, that blood, some of the blood is going to the brain, unfiltered. Because the lungs have macrophages and they filter blood. But now remember, because of the obstruction at the right ventricular outflow tract obstruction, the blood is the shunt at the ventricular septum at the VSD level is right to left. So all that blood is unfiltered and some of it goes to the brain, and they are prone to abscesses. They are also prone to bacterial endocarditis. So management. For neonates, you have to administer prostaglandin so that you keep the PDA open. Acute hypoxia, you have to administer oxygen. These babies who are in third spell, you give them high flow oxygen, put them in chest position, you give them morphine, okay? You can give them beta blockers, rehydrate them, identify the risk factor. If it is infection, treat it. If it is dehydration, correct dehydration, okay? Allez, anxiety. Surgical, we have palliative shunts, like BT shunts. I don't want to go into this because we have run out of time. But basically, we do total correction. Where total correction, you close the VSD and you resect the thick muscle, the infundibulum. If there is a pulmonary stenosis, you can use those Pegas dilators and you open it up. And if the pulmonary valve is so stenotic, sometimes you do a valvotomy and you put a transannular patch. However, they are at risk of a free pulmonary regurgitation. So these are my references. Congenital heart disease is a long subject, but I try to make sure that I try to summarize. Thank you so much for listening.